take it away.
All right, everyone. Well, thanks for joining today. Greetings from Chicago and Lurie Children's. And thank you again for that, for the introduction and the invitation to speak for Peanuts today. So without further ado, let's get started. I have no financial disclosures, although I will be discussing the off-label usage of TPA and mechanical thrombectomy in children. The objectives for my talk today are threefold. I'll begin by defining the incidence, etiologies, and differential diagnosis of childhood stroke. I'll next outline some current recommendations and future directions for pediatric neuroimaging in the acute stroke setting. And finally, I'll summarize the evolution of clinical management for pediatric patients presenting with acute stroke. Throughout my talk today, I'll be presenting some common misconceptions about pediatric stroke, beginning with this one. And we know this is false because kids have strokes more often than thought. So why is there this misconception? Well, there are lots of challenges to diagnosing stroke in kids. Kids are more likely to present with nonspecific symptoms and may be less able to communicate their symptoms to their parents or healthcare providers. Stroke mimics are also really common in kids, much more than in adults, and this further confounds the clinical picture. Unfortunately, these challenges can lead to delayed diagnosis. Another factor that contributes to delayed diagnosis is that often stroke is not the first consideration for presenting symptoms. Median times from symptom onset to presentation have been reported to be up to 21 hours. The diagnostic workup also takes time and may contribute to delays in diagnosis. Improving stroke awareness and imaging efficacy can help counterbalance these issues, and I'll touch on ways to approach this during my talk. So let's first define stroke. As we know, stroke is an acute neurologic deficit attributable to brain cell death in a localized area, secondary to inadequate blood flow or hemorrhage. In pediatrics, there are two types of stroke to consider. First, perinatal stroke is stroke that occurs from 28 weeks of gestation to 28 postnatal days. This is a vast topic in and of itself, which we will not be covering today. For our discussion, we'll be focusing on the second type of stroke in pediatrics, childhood stroke, which is stroke that occurs between 29 postnatal days and 18 years of age. Childhood stroke has an incidence of roughly 3 in 100,000. There are 4 subsets of childhood stroke to consider, the most common of which are arterial ischemic stroke and hemorrhagic stroke. Interestingly, the incidence of hemorrhagic stroke is higher in kids than adults. Let's take a closer look at arterial ischemic stroke. To review, arterial ischemic stroke results from interrupted arterial inflow, which may be secondary to an intraluminal embolus or thrombus, or secondary to intrinsic narrowing of the vessel itself due to an arteriopathy. Intracranial arteriopathies are the largest risk factor for childhood stroke. This group includes pathologies, including focal cerebral arteriopathy, which may be inflammatory or secondary to traumatic dissection, Moyamoya, and vasculitis. Extracranial arteriopathy makes up a separate category, and this is to highlight the prevalence of craniocervical arterial dissection in children, which accounts for approximately 7.5% of childhood ischemic stroke. Cardiac disease makes up the second biggest risk factor for ischemic stroke in kids. These cases are often cardioembolic, secondary to congenital heart disease, procedure-related complications, and acquired heart disease. Thrombophilia is another important risk factor, and these can be inherited or acquired. And finally, systemic causes, including includes diseases such as connective tissue disorders, genetic causes, and metabolic disorders. This first patient is a 16-year-old with remote medulloblastoma resected years ago who was treated at that time with radiation. The radiation therapy unfortunately resulted in bilateral Moyamoya arteriopathy. The MRA at screen left shows severe steno-occlusive disease involving both carotid termini. If we look at the conventional cerebral angiogram of the right ICA in the middle image, we see what classic Moyamoya looks like, with marked spleno-occlusive disease involving the right ICA terminus and the classic puff of smoke collaterals, both findings which are required to make the diagnosis of Moyamoya. By flare at screen right, we see extensive white matter signal abnormality, which reflects chronic ischemia from the Moyamoya arteriopathy. This patient is now presenting with headache. Keep in mind that headache in a patient with Moyamoya is a warning sign for ischemia and an indication for acute imaging. Looking at the DWI and ADC images for this patient, we see a large area of restricted diffusion in the left PCA territory, consistent with acute infarction. This patient also had arteriopathy involving the posterior circulation. This next patient is a 5-month-old with pulmonary artery atresia who presents with right hemiparesis and right facial weakness. By DWI, we see restricted diffusion involving the left MCA territory, confirmed by the low signal on ADC. These findings are consistent with an acute left MCA territory infarction, secondary to embolus in this cardiac patient. At screen right, the FLAIR image shows hyperintensity in the region of infarction, representing early edema. This case represents another classic presentation for arterial ischemic stroke in children in this patient with known congenital heart disease, remembering that cardiac etiologies are the second most common stroke risk factor in kids. So arteriopathy and cardiac disease are both important risk factors for arterial ischemic stroke. What about infection? The VIPS trial investigated the association of infection and arterial ischemic stroke in children. This trial demonstrated an increased risk of ischemic stroke in kids within 1 week following infection. The results also showed an increase in ischemic stroke in poorly vaccinated children. These children additionally had an increased risk of arteriopathy, suggesting a relationship between infection and arteriopathy. Lastly, study results showed that children have a 5-fold increased risk of stroke recurrence if they present with arteriopathy. Ultimately, arteriopathies, cardiac disease, and infection are all major risk factors for ischemic stroke in kids. Let's look at an example of how stroke could develop in children with infection. This is a 4-year-old with recent strep throat who presented altered and with headaches. The CT image at screen right shows enlarged ventricles, which are out of the proportion to the cerebral sulci and concerning for developing hydro. We see intermediate density in the left lateral ventricle, as well as abnormal low density in the left basal ganglia. By MRI, we see acute infarcts in the basal ganglia and thalami, which correspond to the abnormal hypoattenuation we saw on the CT. The MRA at screen right shows a normal circle of Willis without a large vessel cut off to suggest a large vessel occlusion. There is no irregularity or significant narrowing to suggest a large vessel arteriopathy. So what caused the infarcts in this child? This patient was diagnosed with meningitis, which we could have inferred from the enlarging ventricular size and debris in the ventricles. In meningitis, purulent material surrounds the brain and vasculature. In this patient, irritation of small perforating arteries resulted in a secondary vasculitis and subsequent deep gray matter infarctions. This pattern of infarcts is one that we commonly see in the setting of infectious processes, where infarctions occur due to irritation of small perforating arteries by the infection. Secondary vasculitis, as we see in this case, was a prevalent form of vasculitis reported in the VIPS trial. Based on the results of the VIPS trial, it's not surprising that stroke has been shown to occur in children with COVID-19, albeit this is still a rare occurrence. The exact mechanism and incidence remains unclear. One hypothesis is that stroke occurs from a delayed hyperinflammatory response to the infection. This recently reported study demonstrated an increased risk of stroke from COVID-19 weeks following acute infection. Over a third of patients described within the study were interestingly unvaccinated. Let's now look at the second major subtype of pediatric stroke, hemorrhagic stroke. 3/4 of these cases occur due to an underlying structural lesion, such as aneurysm, arteriovenous malformation, arteriovenous fistula, or cavernous malformation. Hemorrhagic stroke may also occur due to an acquired or inherited hematologic cause. All this said, if a child presents with an intraparenchymal hematoma in the absence of trauma, this represents an arteriovenous malformation until proven otherwise, which is the most common etiology of hemorrhagic stroke in children. Let's look at an example. This is imaging for a 17-year-old who presented with acute difficulty walking. The CT images show acute hemorrhage casting the left lateral ventricle with extension into the right lateral ventricle, third ventricle, and fourth ventricles. The subsequently performed CTA demonstrates asymmetric prominent arteries as well as draining veins in the region of the hemorrhage. An AVM, or arteriovenous malformation, was soon confirmed by angiography. This is another case of a 14-month-old who presented with staring spells and increased sleepiness. The representative images from the subsequently performed MRI exam shows multiple bilateral mixed intensity T2 lesions throughout the cerebral hemispheres of varying sizes, and each demonstrates peripheral hemosiderin. There's a dominant lesion in the right temporal lobe that has associated vasogenic edema and local mass effect. Looking to the SWI imaging that was also performed, we can further characterize these lesions. We see several areas of blooming in the parenchyma, which were not as well seen by the concurrently performed T2 image. These areas of blooming represent multiple remote parenchymal hemorrhages. These findings together are most suggestive of multiple cavernous malformations. Unlike arteriovenous malformation, as we saw in the last case, a cavernous malformation is a slow flow vascular malformation which has a tendency to bleed intermittently. This patient appears to have had several prior small bleeds, but the large bleed in the right temporal lobe with surrounding edema led to his presentation with stroke-like symptoms. Now, one cavernous malformation can occur sporadically in older patients. When we see this many cavernous malformations in such a young child, it is most indicative of a familial syndromic cause, which was confirmed by genetic testing. So we've discussed ischemic and hemorrhagic stroke in children. Let's briefly discuss and describe the other subtypes of childhood stroke. This is a 10-year-old with recent fevers presenting with right facial droop and right-sided weakness. On these images from the non-contrast CT exam that was performed, we see multiple abnormal hyperdensities involving the venous structures, including the right transverse sinus, the straight sinus, deep cerebral veins, and vein of Galen. We also appreciate asymmetric abnormal hypodensity in the right temporal lobe and the left thalamus. The subsequently performed MRI a few days later shows that the areas of abnormal hypoattenuation that we saw on CT represent and correspond to areas of evolving infarct in a non-arterial distribution in the left thalamus and right temporal lobe. The extensive thrombus that we saw better on the CT involving the deep cerebral veins has also resulted in extensive vasogenic edema involving both basal ganglia and thalami, as we see in this image. Venous infarct related to cerebral sinovenous thrombosis, as shown here, may be secondary to hypercoagulability or dehydration, which was the ultimate cause of exclusion in this patient. To finish up our discussion of childhood stroke subtypes, here are images of a 6-year-old presenting with transient right upper extremity weakness and slurred speech. Foremost, there is no left-sided infarct to explain the patient's right-sided symptoms as we look at the DWI. We do, however, see a mixed intensity subdural hemorrhage along the left cerebral hemisphere, resulting in mass effect on the left hemisphere and parenchyma, and particularly to the left perirolandic region. Looking at this patient's imaging more inferiorly, we appreciate a large multicystic tumor in the suprasellar region, which contains multiple internal fluid flow levels that we see best on the SWI and FLAIR images. When the patient was taken for hematoma evacuation, the surgeon noted that the tumor itself appeared friable. The tumor, because of this, was presumed to represent the origin of the hematoma, given the internal fluid levels we see by imaging. This patient's presentation of transient right upper extremity weakness was attributed to the mass effect related to the large left subdural hemorrhage. As we know, and to review, transient ischemic stroke is the fourth subtype of childhood stroke to consider. As the name suggests, it represents transient stroke-like symptoms which self-resolve. TIA is important to remember and recognize because this can be a precursor for real stroke. Studies have shown that 10% of children with TIA will ultimately develop a full-blown stroke. So TIA needs to be recognized and diagnosed so that the underlying risk factors can be identified and treated. Now that we've reviewed the common etiologies of pediatric stroke, let's discuss how these children present. Just like adults with stroke, childhood stroke can present with focal weakness or aphasia. However, unlike adults, kids can also present with more nonspecific symptoms, such as altered mental status, headache, or seizure. Unfortunately, many of these signs and symptoms also characterize the presentations of stroke mimics, which makes differentiating stroke and stroke mimics clinically challenging, particularly when you consider that most children presenting to the ED with acute stroke-like symptoms will ultimately be diagnosed with a stroke mimic. All comers, only 1 in 4 children with acute stroke-like symptoms will actually have a true stroke. And this isn't to imply that stroke mimics are benign. Many stroke mimics are serious and require urgent treatment. So whether assessing for stroke or stroke mimics, the imaging evaluation needs to be timely. While there is a fairly broad differential for stroke mimic, the most common entities that we encounter in clinical practice include complex migraine or hemiplegic migraine, weakness after a seizure, which is also referred to as Todd paralysis, and infection. In the next part of this talk, we'll look at various imaging examples of stroke mimics and discuss how neuroimaging can help differentiate these various entities. And to start this section off, let's look at another stroke myth. Children don't experience significant mortality due to stroke. We all know this to be false. Pediatric stroke represents one of the top 10 causes of death in children, with death being more likely in the setting of hemorrhagic stroke. Many children who survive strokes are also left with significant morbidity and permanent disability. These children are also unfortunately at risk for recurrent stroke up to 12% at 1 year. And as I mentioned earlier, if stroke initially presented with an arteriopathy, this further increases the risk of stroke recurrence. Because of the significant morbidity and mortality associated with stroke, the American Heart Association and American Stroke Association released a statement in 2019 on the management of stroke in neonates and children. The idea is that healthcare providers can better treat childhood stroke with an improved understanding of its symptoms, risk factors, and diagnosis. This makes sense, right? Stroke awareness and treatment has been a focus for years in the adult population and has significantly improved patient outcomes. Imaging, as was noted in the statement, plays a central role in early and accurate diagnosis of stroke and its causes. So let's move on to discuss the neuroimaging approach to childhood stroke. So what are the goals of this imaging? Foremost, we aim to confirm the presence of acute and emergent pathology. Second, we want to differentiate acute stroke and stroke mimics. And third, we want to help identify the etiology of acute stroke if present. Let's look at possible imaging options. First, we have the ED neuroimaging workhorse, a non-contrast CT head. This is quick and readily available at almost every ED. It doesn't require sedation, and it can quickly determine if there's an intracranial hemorrhage. However, it does require radiation, which, as you all know, we try to avoid in peds. And most importantly, it can be inconclusive for the identification of acute ischemic stroke. Studies have shown that CT can fail to diagnose childhood stroke in a large proportion of patients. The next scan to consider is a CTA head. This too is readily available in most EDs and relatively quick to perform. This is also the standard of care for a non-invasive assessment of the cerebral arteries, but it does require radiation, intravenous contrast, and IV placement. The third scan to consider is a non-contrast MR brain. This is a longer exam and may be less available than CT in the acute setting. On the plus side, MRI requires no radiation, and most importantly, it has a high sensitivity for detecting acute infarct. This exam does not require contrast, IV placement, or radiation. As an alternative to CTA, we can also perform an MRI of the head. This exam also has no radiation, does not require contrast, and can help us identify large vessel occlusions and arteriopathy. Keep in mind that CTA exams are still more sensitive than MRA and truly represent the standard of care for evaluation of the cerebral arteries. Non-contrast CT head and CTA head and neck exams really drive stroke codes in adults. So why do we focus on MRI for peds? Foremost, it allows us to avoid radiation and work towards a LARA. Second, MRI is more sensitive for early stroke detection and can be identified within 30 minutes of stroke occurrence. Studies evaluating childhood stroke out of major pediatric centers have shown that initial CT imaging fails to identify stroke in a large proportion of children with true stroke. One study reported numbers up to 47%. Also, MRI is key for differentiating stroke and stroke mimics, and this comparison is not possible or easily done by CT. During a stroke code at Lurie Children's, this is how imaging proceeds. If patients are cleared for MRI, we proceed with non-contrast MR brain and non-contrast MRA brain exams. However, if the patients are not cleared for MRI, for example, in a cardiac patient with a retained lead, patients will go for non-contrast CT head and CTA head and neck imaging. In contrast to what may be seen at adult centers where imaging is CT driven, pediatric stroke protocols, as we've mentioned, are MR driven. This again is because MRI has high sensitivity for acute infarct, can adequately differentiate stroke and stroke mimics, and does not require radiation. Here are the important sequences that we include within our acute stroke brain protocol. DWI helps identify acute infarction. SWI helps identify intracranial hemorrhage. FLAIR helps identify edema and any parenchymal signal abnormalities that may be seen with stroke or stroke mimics. The ASL imaging or non-contrast perfusion imaging helps evaluate cerebral blood flow and is helpful to identify tissue at risk as well as stroke mimics, as we'll look at. And finally, an MRA brain exam is routinely performed as part of our stroke protocol. This component helps evaluate for large vessel occlusion and large vessel arteriopathy, which, as we know, is an important risk factor for stroke. This imaging approach allows for rapid institution of therapies for both stroke and stroke mimics and helps work to reduce morbidity and mortality in our patients. Let's look at some examples. This is a 5-year-old presenting with facial droop after new seizure-like activity. The axial DWI image at screen left from his rapid MR brain exam shows no acute infarction. The middle SWI image shows no intracranial hemorrhage. However, if we look closer at the SWI image, we do see that there are asymmetrically prominent cortical veins along the left cerebral hemisphere. The MRA head image at screen right shows corresponding asymmetrically decreased prominence of the arteries in the left cerebral hemisphere. These findings are consistent with Todd paralysis, which represents a focal neurologic deficit after a seizure. When looking at these images, note the added value of having SWI included in the protocol. This is one of many examples of why many pediatric hospitals routinely use SWI rather than GRE in their imaging protocols. Our next stroke code is a 13-year-old with acute lymphoblastic leukemia, status post-recent intrathecal chemotherapy, who presents with left arm and left leg weakness, as well as aphasia. DWI and ADC images demonstrate subtle restricted diffusion in the cerebral white matter. On FLAIR, there is corresponding faint hyperintense signal in these areas. So we have restricted diffusion and edema. Does this mean this is a stroke? Taking a look at the MRA, we don't see any evidence of large vessel occlusion. This patient received IT methotrexate chemotherapy days before his presentation for ALL. In this setting, this is most consistent with methotrexate leukoencephalopathy. The follow-up imaging performed 10 days later, as shown here, supports this diagnosis. We see interval resolution of the previously visualized restricted diffusion in the cerebral white matter bilaterally, as well as evolution of subtle FLAIR signal abnormality in these locations. We'll next discuss some advanced neuroimaging techniques that are helpful in the pediatric stroke workup: arterial spin labeling, MR spectroscopy, and vessel wall imaging. We'll now look at each of these in turn, beginning with arterial spin labeling, or ASL. ASL is a non-contrast perfusion technique that estimates cerebral blood flow, where cerebral blood flow, or CBF, is a biomarker for brain tissue metabolism and physiology. This sequence is also key in differentiating stroke and stroke mimics. I have displayed an example of normal ASL here. Just like contrast-enhanced perfusion techniques, a normal ASL scan will demonstrate increased flow in metabolically active areas like the cortex and the basal ganglia and thalami, with relatively decreased flow in the cerebral white matter. As you can perhaps tell from the imaging, ASL has lower signal to noise than contrast-enhanced perfusion techniques. For those of you who have worked in an adult ED reading room in the last decade, you have experienced firsthand that CT perfusion is commonly performed in the acute stroke setting for adults. CT perfusion helps assess for stroke and salvageable brain tissue. That said, we don't like CT perfusion in children due to its high radiation exposures, which is much greater than CT and CTA. This exam also requires IV access and iodinated contrast, and not to mention absence of motion. ASL is an awesome alternative to CT perfusion for children. It allows so that we can get an estimation of cerebral blood flow without the need for contrast. As an MR technique, ASL also has all the advantages of MRI. There's no radiation, no contrast, no IV access. We also, because it's non-contrast, we don't have to worry about gadolinium exposure. Also, to highlight, because we don't need to time a contrast bolus, we can repeat this as many times as needed to get a diagnostic sequence. As we saw on the last slide, one of the drawbacks of ASL is the lower signal to noise ratio in comparison to other perfusion techniques. So how does this work in practice? There are a few types of ASL used in clinical practice throughout the United States, but in general, in each technique, inflowing arterial blood water will be labeled by a pulse sequence at the level of the neck. There'll be a post-labeling delay, which allows for the labeled blood to flow into the brain tissue to about the level of the capillary bed, and then an image will be acquired. We'll next look at a series of stroke codes to show how this technique can be used in clinical practice. This is a 14-year-old who presented with acute onset headaches. The CT image at screen left shows acute intraparenchymal hematoma in the splenium of the corpus callosum, with blood casting the lateral ventricles. It's helpful to note that the intraparenchymal hemorrhage in the corpus callosum is very unusual and not something that we commonly see. The SWI MRI image from the subsequently performed MR brain exam redemonstrates the hematoma. We also see that the ventricles are decreased in size because they've placed an external ventricular drain. You may remember from earlier in my talk that non-traumatic intraparenchymal hemorrhage in a child is an AVM until proven otherwise. We know that AVM is a high flow shunting lesion. So can we evaluate for this kind of high flow with ASL? And the answer is yes. If we look at the ASL image from the same exam, we see light bulb bright signal in the region of the hematoma. This represents hyperperfusion and is most consistent with high flow AV shunting. The follow-up conventional cerebral angiogram at screen right confirmed the presence of an AVM in this location. ASL helps make this diagnosis so much easier. And think about the potential morbidity prevented if we were to identify the AVM before this lesion bled. This next patient is a 16-year-old presenting with altered mental status, headache, and aphasia. Axial DWI and ADC images at screen left show no evidence of acute infarction to explain the patient's symptoms. On the ASL image, there's no acute hemorrhage. We do, however, see asymmetric prominence of the cortical veins in the left cerebral hemisphere. The ASL image at screen right demonstrates a large area of dark signal in the left cerebral hemisphere. This is what hypoperfusion looks like by ASL. In the setting of headache, these imaging findings are most consistent with hemiplegic migraine, which it turns out this patient had a family history of upon further investigation. In this case, the SWI and ASL sequences are essential for making the imaging diagnosis of complex migraine. This next patient is a 19-month-old with new seizures. The DWI images show bilateral infarctions in the occipital lobes. On ASL, there are large areas of decreased perfusion in the same areas. The MRA image shows irregularity and narrowing of the right vertebral artery, which was secondary to arterial dissection. Taking a closer look at the ASL image, we can appreciate that the area of hypoperfusion is larger than the areas of restricted diffusion. And this is highlighted by the yellow coloring. This is what is referred to as a diffusion-perfusion mismatch, as we showed by the yellow markers. This finding helps identify potentially salvageable brain tissue or penumbra. This is another patient, a 6-year-old with altered mental status. The acute stroke imaging performed for this patient shows no infarction on DWI. The ASL imaging at screen right shows hyperperfusion involving the left frontal cortex, as denoted by the arrows. Taking a closer look now at the other imaging shown, we see very subtle corresponding signal on the FLAIR and DWI images, which admittedly, in the absence of the findings on ASL, is difficult to identify. These findings are secondary to recent seizure activity, which was the reason for the patient's acute presentation. Take a second to appreciate how much easier ASL makes this diagnosis. This is imaging for a 10-year-old with complex congenital heart disease who presents with new right-sided weakness. The acute stroke MRI shows a small acute infarct in the left basal ganglia. The concurrent ASL images show asymmetric hypoperfusion involving the left cerebral hemisphere. We also see small areas of bright signal along the left frontal cortex, denoted by the arrows. The arrows are pointing to foci of arterial transit artifact. Arterial transit artifact occurs when labeled blood is located within the large cerebral arteries and not the parenchyma at the time of image acquisition. In this example, this finding implies that something has delayed flow of the tagged inflowing arterial blood into the left cerebral hemisphere. Taking a look at the currently performed MRA head exam, we don't appreciate a hemodynamically significant stenosis that could have resulted in delayed inflowing arterial blood flow. A follow-up MRA neck exam was recommended to further evaluate for an upstream stenosis. This exam showed severe stenosis involving the proximal left common carotid artery, which was confirmed by angio prior to stenting. As a final note, automated software has been developed for adults to help quickly identify salvageable brain tissue in the acute stroke setting. This is currently in routine use in adults. To date, some groups have retrospectively applied this technique to small cohorts of pediatric patients, and folks are currently at work trying to apply this technology in peds. In addition to perfusion imaging, MR spectroscopy is another advanced sequence to consider to help hone the differential for acute stroke-like symptoms, and we'll talk about this next. As a big disclaimer, this is a longer sequence and should not be routinely done during an acute stroke protocol. The way to think about MR spectroscopy is that brain tissue in different states has different concentrations of metabolites, which we can measure using this technique. The most important metabolite to consider in the setting of stroke is lactate, which is a marker of anaerobic metabolism. Lactate can also be seen with metabolic disorders, and its identification with MR spectroscopy can be used to help differentiate stroke and stroke mimics. It's important to remember that MR spectroscopy will be most clinically helpful if you have a specific clinical question in mind. The example MR spectra shown here is an example of normal. If lactate were present, it will occur as a peak at 1.3 parts per million, or the area denoted by the arrow. Let's look at an example of how this sequence can be useful. This is a 15-year-old with known MELAS, or mitochondrial encephalopathy, lactic acidosis, and stroke-like episodes, who presented to the ED with new seizures. On this patient's imaging, we see cortical subcortical areas of flare signal abnormality in the left occipital lobe, bilateral temporal lobes, as shown at screen right. And these areas of signal abnormality represent areas of prior injury. We also see abnormal restricted diffusion in the right basal ganglia. So let's look at how MR spectroscopy can help differentiate MELAS from stroke. When we evaluate the normal appearing white matter in the right occipital lobe by MR spectroscopy, as shown here, we see abnormal lactate at 1.3 parts per million within this tissue. The box denotes the area evaluated with MR spectroscopy. Abnormal lactate peaks and normal appearing white matter is diagnostic of MELAS and can help differentiate this entity from acute stroke. This sequence can be performed in unconfirmed cases, first to aid diagnosis, second to suggest the need for genetic testing, and third and most importantly, to direct acute therapies for metabolic crisis. The final advanced imaging technique to discuss and to consider in the pediatric stroke workup is vessel wall imaging. I want to begin with another big disclaimer that the resolution requirements needed for these sequences result in long scan times and often necessitate sedation. This is certainly not amenable to the acute stroke setting, but can be useful during the subsequent stroke workup. So conventional angiography techniques like CTA, MRA, DSA assess the vessel lumen. Vessel wall imaging is unique in that it evaluates the wall of the vessel itself. Vessel wall imaging can be a useful adjunct to these more conventional angiography techniques and can help identify vessel inflammation in the setting of suspected vasculitis or inflammatory focal cerebral arteriopathy. Here's an example of how vessel wall imaging can play a role in clinical practice. This infant presented with encephalopathy. The post-contrast T1 images show diffuse basilar enhancement. The DWI imaging shows bilateral multifocal infarctions. MRA shows narrowing and irregularity of the bilateral M1 segments. On evaluation of the vessel wall imaging, we see circumferential vessel wall enhancement, which is best appreciated on the sagittal reef formats shown here. Note how vessel wall enhancement is more extensive than the narrowing that we see by MRA. In this case, vessel wall imaging also helped differentiate the vessel wall enhancement from adjacent basal cistern enhancement. Remember in these cases to use the coronal and sagittal reformatted images to best evaluate the vessel wall. And finally, for our last stroke myth, there is no effective treatment for childhood stroke. Well, that's not exactly true. To date, there are no published clinical trials investigating acute endovascular interventions in children. Before we look into what is available for pediatric stroke therapies, let's review what's worked and led to success in adult stroke management. As you may be familiar with, in adults, dedicated stroke centers have been designated with dedicated stroke teams. Stroke codes exist as a collaborative effort between neurologists, neurointerventionalists, and radiologists to facilitate rapid stroke evaluation and treatment. These centers also have at their disposal the ability to administer revascularization therapies. In adults, thrombolytic therapy can be performed up to 4.5 hours from the patient's last known normal. There have also been several adult stroke trials looking at mechanical thrombectomy. In 2015, 5 early window stroke trials showed a benefit of mechanical thrombectomy at 6 to 12 hours following symptom onset. Most recently, the Diffuse 3 and Dawn trials demonstrated that it can be safe and effective to perform mechanical thrombectomy up to 24 hours following a patient's last known normal in certain clinical scenarios. Given the efficacy of these therapies in adults and associated improved patient outcomes, centers are trying to adopt these same strategies and therapies in children. The TIPS trial was a safety and dose-finding study of TPA in children between 2 and 17 years who were diagnosed with stroke within 4.5 hours of symptom onset. This trial was unfortunately closed at 1 year due to poor enrollment. TPA is currently not FDA approved for use in kids. Off-label TPA usage is still possible, especially in teens. What about mechanical thrombectomy? Endovascular therapies are currently not FDA approved for acute stroke in children. A few retrospective studies have attempted to evaluate the case studies and case reports available in the literature. The results of one such meta-analysis are shown, which demonstrate promising recanalization rates and long-term patient outcomes. Still, more data is needed to confirm these results. Finally, let's end with this case. This is a 15-year-old with sudden onset expressive aphasia and right-sided weakness. The non-contrast CT head performed 1 hour and 10 minutes following this child's last known normal is thankfully normal. CTA imaging shows occlusion of the proximal left MCA as shown in this reconstructed image. The patient was given TPA at 2 hours and 10 minutes without improvement. Subsequently, the patient was taken for thrombectomy at 4.5 hours from last known normal. We can see here the pre-thrombectomy image showing the MCA occlusion, and the post-thrombectomy image is at screen right, demonstrating successful recanalization. This is the patient's CT imaging 1 month later, which is completely normal. So in conclusion, timely recognition and diagnosis of pediatric stroke is important but challenging. Remember, children have nonspecific symptoms and stroke mimics are common. The broad differential for stroke-like symptoms in children can be narrowed with effective neuroimaging techniques like ASL. Pediatric stroke education is fundamental for improved outcomes in childhood stroke. Outcomes like the last case I showed are possible and define what we're striving for through increased pediatric stroke awareness and education. And this is why I chose this lecture topic today. And with that, thank you all for your attention.
Thank you so much, Sarah. That was an incredible talk. Definitely a lot to think of, definitely something we see in practice every day, and something clinically that's very challenging, for clinical colleagues, and somewhere as neuroradiologists, we can really, help both with the diagnosis and help, kind of guide management. So I think that was awesome. We have a couple questions and comments in the chat, if that's okay. The first one was asking about that the first case question whether it was migraines versus postictal changes. I think you talked about it a little bit, but do you want to just, clarify how can we differentiate postictal changes versus post-migrainous changes, I guess, on the MR?
I think it can be hard especially in the absence of clinical history, because especially if you look into what has been reported in the literature, they can have similar findings. Both of them can have the hemispheric hypoperfusion, and they can have similar kind of attenuation of the cerebral arteries, and as well as the prominence of the cortical veins. I think clinical history is key. Also, different phases of migraine will have different perfusion findings. So one phase of a migraine may have the hypoperfusion, while others may have hyperperfusion. But I think it can be clinically challenging. It's always, I think, especially if you don't have the clinical history to help, recommending EEG is never incorrect when you're reporting these cases out.
Great. Let's see, another question. How do you differentiate vessel wall enhancement from leptomeningeal enhancement, like in that meningitis case?
I think it can be challenging. The case I showed, I think it's most helpful to use the reformatted images. I showed a donut on that slide. I feel like sometimes it tend to have that appearance, but really try to, I think if you're only looking in one plane, it does make the evaluation challenging. So I think using the coronal and sagittal reformatted images, depending on the direction of the vessels, can be extremely helpful, but it certainly can be challenging. The vessel wall imaging certainly needs to be optimized for evaluation as well, and artifact free.
Great. And I assume you guys do pre-contrast ones also to look for dissection as well, like you do pre and post.
Yeah, so standard,
yeah.
So we'll do pre and post. At our institution, we have space, so we'll do pre and post space to look for dissection and then to look for enhancement.
Okay, another question. Manish Bajaj says, great talk, wonderful cases. He's wondering if ASL was performed in that tumor case with the fluid levels and the hemorrhage with the TIA, and if there was any symmetric perfusion there.
I didn't show the images, but we did on a follow-up, we did do perfusion imaging for that patient. And interestingly, the patient did have hypoperfusion in the left cerebral hemisphere. She ended up, and it was recurrent and intermittent, not consistent. So she ended up going for revascularization to help improve her symptoms.
Wow.
The thought process was that the hemorrhage had affected kind of her collaterals to the territory.
Okay, yeah. I mean, was there narrowing on the MRA also, or the whatever vascular imaging? Was it like encasing the vessels? Or I'm trying to remember if you showed that, or
I didn't exactly show that.
Okay.
Not in the case, but I think there was a little. The vessels were affected peripherally, but yeah, I didn't show those images in the talk.
And the question was it a cranial? What was the diagnosis of the tumor? What was the pathology?
Ganglioma, I believe.
Ganglioma. Okay, yeah, I think that was the question. Okay. Any other questions from the group? Do you, as part of your stroke protocol, do you take patients who are off of the scanner if they're being scanned when the patients present? Because we used to more, and now our new stroke protocol is if there's somebody on the table, then we go to CT-CTA instead.
Fair. I mean, I think it's hard. It doesn't come up that often, where I think because of transport logistics, usually we're able to finish imaging and have a scanner available. So we'll have, at any given time, we have, usually the scanners are turning over that it hasn't been a problem consistently. But I think it is a process in place that it'll be a discussion if we need to remove a patient. So we are willing to do that, but we're not directing patients to CT, CTA. That hasn't come up in our algorithm yet.
Okay.
But right now we'll remove patients for scanning, but it doesn't happen that often or commonly.
And if you see something on your stroke protocol, well then will you add on some stuff like vessel wall imaging kind of at that time, or will you just kind of do your stroke protocol and then bring them back for additional imaging if they need it?
For vessel wall, we really bring them back for those exams. We try not to do them in the acute stroke setting. I mean, especially, just in terms of MR workflow, usually stroke codes aren't planned, and there are additions to the schedule. So we'll do this stroke workup, our imaging, it'll be about a 15-minute exam, including all the sequences I showed. So we'll get that done, and then we'll bring them back if after further evaluation and assessment of the patient, there's concern for vessel inflammation. So we'll do that as a later assessment. And oftentimes it's something that, depending on the age of the patient, we may need sedation for as well.
Mm. Any other questions from out there on the internet? I guess you answered everybody's questions. Everybody's an expert in pediatric stroke now. You just have to do the follow-up neonatal stroke talk.
I'll work on that.
Yeah. Well, thank you so much, Sarah, for this wonderful talk. And thank you everybody else for listening. Next month will be your colleague also from Lurie, Jesse Zaretic, who'll be talking about pediatric cervical spine. So I hope you will all join us then. And also this and other lectures will be available on YouTube for later viewing if anybody missed it or anybody wants to see it again. Cool. Thank you so much, everybody. Have a great month. Thanks again, Sarah.